Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
It's so nice to have you here with us to talk a bit about triple-negative breast cancer and some of the latest advances with triple-negative breast cancer. I'm Rita Nanda. I am the director of the Breast Oncology program here at the University of Chicago, and I'm joined by Dr. Aditya Bardia, who is a professor of medicine and director of the breast program at UCLA. Here are our learning objectives for the next 1 hour. Which aspect of triple-negative breast cancer do you find most challenging when managing patients? Is it the aggressiveness, the tumor biology, and the high recurrence rates? Is it that there are limited treatment options, that patients don't do very well, particularly in the metastatic setting, or a lack of clear subtyping, that we don't know what subtype of triple-negative breast cancer patients have? So please vote here so that we can understand what the concerns are you have in your personal practices and what challenges you face when you're dealing with patients with advanced triple-negative breast cancer. And thanks to everyone for being so engaged. It's really wonderful to have that engagement so that we can be certain to tailor the program to your needs. And it looks like a little bit of differences in what people find challenging. Most of you said the aggressiveness and the high recurrence rates, which of course can be quite challenging, and then poor patient prognosis. Those were kind of the two most frequent concerns that people had, and then also the limited treatment options. But fortunately, we've been improving on those treatment options, in the last several years. So triple-negative breast cancer, as you all know, is a form of breast cancer that is defined by the lack of expression of ER, PR, and HER2. And triple-negative breast cancer has a tendency to be more common in certain patient groups. We know that younger women, premenopausal women, are at higher risk for TNBC than older postmenopausal women. We know those who are Black or of Hispanic ancestry are at higher risk. And we also know that individuals who harbor deleterious germline mutations in BRCA1 have a high risk of developing triple-negative breast cancer. About 80 to 90% of patients who have a BRCA1 mutation, if they develop breast cancer, will develop triple-negative breast cancer. It's not entirely clear why that is. With BRCA2, we see a split. It's more similar to what we see with sporadic breast cancer, but with BRCA1, obviously, we see a much higher incidence. We know that triple-negative breast cancers can behave aggressively. About 30% or so have a tendency to recur in patients who have a diagnosis of early-stage breast cancer. Although I would say that I think we're moving the needle here with the addition of platinum-based therapies, as well as immunotherapy in the early-stage triple-negative breast cancer setting, but it still remains a concern. And we know that for those individuals who have developed metastatic triple-negative breast cancer, either de novo or recurrence after early-stage disease, that the median overall survival is quite poor, generally under 2 years, although we are making improvements. And it can be highly variable. There are some patients who don't do well at all, and then other patients who can respond very well to some of the newer therapies that we've got. And so it's really exciting to think about the advances we made in the last several years. Historically, treatment has been limited to chemotherapy, but we have PARP inhibitors, immunotherapy, now antibody-drug conjugates for at least subsets of patients with TNBC. We know that after a diagnosis of early-stage TNBC, there's a high risk of early recurrence. So unlike hormone receptor positive disease, where we see later recurrences, we know that with TNBC, the vast majority of patients who recur will recur early, and they will recur with visceral disease. So lung mets, liver mets, even brain mets, although it's not generally the site of first recurrence, but it can be. But about 50% of patients with metastatic TNBC will develop brain metastases over the course of their metastatic journey. And we know that the survival, again, in the metastatic setting is not as good as we see with other forms of breast cancer. Triple negative breast cancer is about 15% of all breast cancers. And as you can imagine, because these are tumors that are lumped together because of the lack of expression of ER and PR and HER2, it's a pretty heterogeneous group of tumors. Now, there have been different groups that have done molecular profiling on triple negative breast cancers, and you can see here that in general, triple negative breast cancer kind of clusters within these 4 distinct subtypes. Each group has called them somewhat a little different names, but they're typically those tumors that are driven by sort of androgen receptor signaling. So the androgen receptor positive triple negative breast cancers, again, a minority of patients have this form of breast cancer, but that's a subtype. Those that are characterized by a robust immune infiltrate in the tumor microenvironment, those that are not inflamed at all and aren't generally amenable to immunotherapy, and the mesenchymal subtype, which generally carries a pretty poor prognosis and poor response to chemotherapy. You can see that stage by stage, triple negative breast cancers have a poorer prognosis as compared to other subtypes in triple negative breast cancer. Here in kind of the aqua color, you can see that for stage 2, stage 3 disease, triple negative breast cancers have the highest risk of recurrence and the poorest overall survival. And the same is true for advanced stage disease or stage 4 disease. Now, we've certainly made progress in the last few years, but we've also made progress for the other subtypes as well. So it really does remain the subtype with the poorest long-term outcomes in the setting of metastatic disease. And as I'd mentioned earlier, triple negative breast cancer in that graph there on the lower hand left side, you can see that in the green, that triple negative breast cancer has a tendency to recur early. For the most part, patients who have triple negative breast cancer will recur within the first 3 to 4 years of diagnosis, and then the risk of recurrence really drops off pretty precipitously, unlike hormone receptor positive disease in the aqua, where you can see that the risk of recurrence remains persistent over several years. And so many of these patients can recur later. Biomarker-driven therapy, however, is becoming a reality for triple negative breast cancer. As I'd mentioned before, we look at these 4 different subtypes. The immune-enriched subtypes, these tumors can be characterized by PD-L1 positivity, a lot of tumor-invasive lymphocytes within that tumor microenvironment, a high tumor mutational burden, mismatch repair, microsatellite instability, all make these tumors amenable to immunotherapy. We have pembrolizumab that is available, and we're going to review some of those data. Those tumors that are characterized by impaired DNA repair capabilities, such as those which occur in the setting of germline BRCA1 and 2 mutations, can be amenable to therapies like PARP inhibitors. Olaparib and talazoparib are both available. We know that a subset of triple negative breast cancers are characterized by alterations in the PI3 kinase AKT mTOR-P10 pathway. Unfortunately, PI3 kinase inhibitors and AKT inhibitors haven't really panned out, at least for triple negative breast cancer, but studies are ongoing. So it remains to be seen if any future studies will be positive, but to date, a bit disappointing when combining these agents with chemotherapy. And then, as I'd mentioned before, a subset of triple negative breast cancers are characterized by androgen receptor expression. This is a minority of triple negative breast cancers. These tumors generally have a tendency to be a little bit more indolent, but there are studies looking to repurpose therapies that are used to treat prostate cancer, because most prostate cancers are androgen receptor positive for this subset of triple negative breast cancers. And then a whole host of antibody-drug conjugates. We have 2 that are approved, sacituzumab govitecan and TDXD, or trastuzumab deruxtecan, and we're going to talk about the data that led to the approval of these agents in a moment, and then some novel ADCs, and there are a whole host of them. We're not going to really, in the interest of time, cover those today, but I think we have many other therapies to look forward to in the future.
So let's ask another question, which is, what do you believe is the most important aspect for patient-centered care in TNBC treatment? Clear communication, comprehensive support treatment, personalized treatment, or access to new therapies? Please send in your answers. Yeah, personalized treatment, I think that is critical. We are in the era of precision medicine. It's about not only looking at biomarkers, but also understanding patients' preferences, their needs. Some side effect might be more problematic for one patient than the other. It also incorporating their lifestyle. For example, if a patient is traveling or lives away from healthcare center, a side effect like diarrhea could be much more problematic. So personalized treatment plans are critical for management of a patient with metastatic breast cancer.
So one of the questions that came through the chat, I'm happy to take it or you can, but really specifically about biomarkers that can improve stratification, treatment decision-making, and outcomes for patients with triple-negative breast cancer. I think, we did not review it today, but there's a really wonderful table in the NCCN guidelines, and I highly recommend that people refer to that if they don't know, what all to test their patients for. But we talked about PD-L1 being critical. So assessing a PD-L1 status using the combined positive score, I think, is critical. You want to make sure that if patients are eligible for chemoimmunotherapy, that you figure that out upfront, because that is one of the treatment strategies that's associated with a survival advantage. And so we definitely want to give patients that opportunity to have a survival advantage. Looking for germline BRCA1 and 2, obviously, we've got the PARP inhibitors. They've been shown to be more effective, more tolerable, associated with a better quality of life. Oral agents for patients who have germline BRCA1 or 2 mutations. So those are the two that are highest yield. But then there are a whole host of other things that we can get with next-gen sequencing and fusion analysis, looking for NTRK fusions, RET fusions, mismatch repair, microsatellite instability, a high tumor mutational burden. All of those abnormalities have tumor type agnostic indications for targeted therapies, either immunotherapy or other targeted agents. And so it's very important to think about those. It's a minority of patients with breast cancer, a minority of patients with metastatic triple-negative breast cancer who have those abnormalities, but it's certainly worth testing because, again, you want to make sure that we give patients all of the opportunities for therapies that we've got that can improve their outcomes. So I don't know, Dr. Bardia, if there's anything else that you wanted to add there that I left off that list.
I fully agree. I think these three biomarkers, PD-L1, germline BRCA, as well as the HER2 status, and if a patient has both, say, germline BRCA and PD-L1 positive TNBC, in general, we recommend immunotherapy given the survival advantage, as you mentioned. And then in the second line setting, you can use a PARP inhibitor, which has shown improvement in PFS and a trend towards improvement in survival. So usually in the second line setting. So I follow a similar practice.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.